So we use Brentuximab Vedotin in different scenarios. I being a transplanter, my most often indication is in patients with high risk of relapse who underwent autologous stem cell transplantation to use Brentuximab Vedotin single agent every 3 weeks for 1 year as a consolidation/maintenance strategy, which was shown in the ETHERA trial to be superior to improve the progression-free survival compared to placebo. So that is one of the most common indication that I use in my practice. I also recommend using AAVD in the populations where I think patients will benefit. And I have seen Brentuximab Vedotin is quite, the toxicities are quite manageable. Again, as a transplanter, I like to take my patients to the transplant if possible in a PET negative status, and hence if somebody relapses after ABVD and they are still PET positive prior to the transplantation, I often used Brentuximab Vedotin to make them PET negative and then take to the autologous transplant and then put them on the BV maintenance/consolidation for 1 year, and I am seeing pretty good result with this type of combination treatment. One has to be careful about the toxicities and adverse events in this type of approach. Brentuximab Vedotin is known to cause peripheral neuropathy, and in Echelon trial, almost 2/3 of the patients developed some form of peripheral neuropathy. Good news is grade 3 or 4, that means advanced cases of peripheral neuropathy, were not very common. I think the incidence was in the figure of teens, like 11, 12, 13%. The good news is those patients who developed peripheral neuropathy, almost 2/3 of them completely resolved their peripheral neuropathy over several months after stopping the therapy. Hence, it is very important to counsel the patients. Counsel the patients before starting Brentuximab Vedotin. What we do in our practice, first of all, I thank all our nurses because they are in the forefront. They identify those early symptoms. Often our nurses are really excellent in identifying if someone was enjoying crocheting and now cannot do the finer movements, cannot button the shirt, or cannot pick up a dime that dropped on the floor. And those are early subtle signs of peripheral neuropathy. So vigilance, early diagnosis, and then based on that, dose adjustments or dose reductions or dose delays. By doing that, we often either halt or prevent the further progression of peripheral neuropathy. And then after the end of the therapy, we have seen almost 2/3 of the patients completely resolve, and rest, almost half of them, improve more than 50% of their symptomatologies. Unfortunately, 10 to 15% of the patients are left with peripheral neuropathy at the end of the therapy, and hence again identifying them right in the beginning and being vigilant is the main important step for any oncologist treating patients with BV. So Dr. Galal, could you please let us know when do you use BV in your own patients, and give examples for some patients who you would consider their use?
I do use BV quite frequently in my own patients in different situations. So the first one is the classical Hodgkin's lymphoma, where it's indicated in the frontline therapy for higher stage Hodgkin's lymphoma stage 3 or 4. These patients benefit a lot from a combination of Brentuximab Vedotin and the chemotherapy. Their outcome is very good, and by using the growth factors like Neulasta or GCSF, we come around the risk of febrile neutropenia and neutropenia in general. The peripheral neuropathy is very well tolerated in general and reversible, even for the patients that have irreversible type of peripheral neuropathy. They do have a lower grade eventually from that peripheral neuropathy. So I do use it in that kind of population. Also in the peripheral T-cell lymphoma and cutaneous T-cell lymphoma. As a matter of fact, I do have a big population of cutaneous T-cell lymphoma being treated in my clinic, and I use Brentuximab Vedotin very often once they have CD30 positivity. In the classical Hodgkin's population, I've seen very good response rate with sort of judged by the PET2 negativity. So I can tell you 99% of my patients actually had negative PET scan after the second cycle, presenting with very advanced disease and bulky disease as well. Most of my patients in that kind of category, so far they were younger population, so they tolerated the combination very well without any admission for fibrillar neutropenia, and they do receive the growth factors effectively. So I have seen really very positive outcome from that population. Haven't had any patients that been relapsed as of yet, and hopefully not. However, we monitor them very closely for that. In the peripheral T-cell lymphoma, I've seen very good response rates, especially in the anaplastic large cell lymphoma. The question with the longer follow-up, how durable is that in this kind of category of patients? Because it is a tough disease to treat. So other than the good response rate and changing actually our approach to treating these kind of diseases, the side effects are very well known, and we're quite aware of it, and we manage it very well. We can reduce the doses based on the degree of the peripheral neuropathy and based on the kidney or liver function. So we're quite educated about it, and we know we can expect the side effects and deal with it. So we don't tend to delay any therapy, especially in the Hodgkin's lymphoma patients. I think BV did change the approach to the frontline therapy for advanced stage Hodgkin's lymphoma. Based on the Echelon-1 trial results showing the modified progression-free survival advantageous in favor of the A+ AVD, and showing the reduction of risk by 23% of death or progression. And this actually reinforced by the 3-year data discussed at ASCO this year, and also the North American experience that showed the modified progression-free survival and the progression-free survival both are in favor of the A+ AVD. So I mentioned in the frontline therapy, but also in the relapsed refractory, the use of bendamustine, brentuximab, or the bendamustine plus nivo or any other checkpoint inhibitor has opened the door to more treatment and better responses, and might get the patients to transplant if they fit for transplant, or even having durable responses if they don't fit for the transplant with a frequent follow-up.